Our next speaker is Sun Hun Park. We call him Sean. We've anglicized his name. Sean is the largest implanter of penile implants in Asia, and has his clinic in Seoul, Korea, where he does all his implants under local. Sean has been one of the pioneers of the new subcoronal incision. You know, this operation of penile prosthesis has been around for more than 40 years, and here we have a new incisional approach, and Sean has been one of the pioneers of it. So, Sean, if you'll come and give us a paragraph about why you like this particular approach.
Good morning, gentlemen. Thank you for the introduction. So, almost all my virgin patients are done under local anesthesia. When I tried local anesthesia with the scrotal approach, after I injected those local anesthetics to the scrotum, surgical planes are kind of obliterated. So it's hard to really find where the diastasis layers were. So after I converted the subcoronal approach, since the plane is quite different, it is much feasible with the local anesthesia. The second part is that after you do the subcoronal approach, one really don't have to worry about the postoperative hematoma. When it comes to the postoperative hematoma after the scrotal approach, or either a infrapubic approach, when the incisions break down and the bleeding comes out, there's kind of emergency. But with the subcoronal approach, one doesn't have to really worry about that.
Subcoronal inflatable penile prosthesis surgery under local anesthesia with modified Wilson's Deaver maneuver. Stepwise injection of local anesthetics during the surgery will minimize patient discomfort. Before the incision, pudendal penile root inguinal canal block is done. Adding local just before listed steps demonstrated during the video could maximize the anesthesia. Subcoronal approach is quite similar to scrotal approach. These key points shown in this video clip could help preventing surgical complications like crossover during the dilation, postoperative scrotal tubing protrusion, or penile edema. Preoperative trimix was injected for corporal relaxation. Local anesthesia starts with bilateral pudendal block, then conventional penile root block, then direct inguinal ring block. After identifying the right inguinal canal through the scrotum, needle was introduced to the ring guided by right index finger. 3M utility drape was applied to prevent sucking. Circumferential subcoronal incision was done. Dartos fascia was dissected with mosquito clamp. Since there are two dartos layers, care was taken for complete dissection of each layer. Gentle penile developing was done. Right proximal corpora was exposed with step-by-step method. After adding local anesthesia, dissection with gauze and baby Richardson was carried out until ischiocavernous sus muscle is exposed. Left proximal corpora space was developed with same method. Scrotal septum was dissected with modified Wilson's Deaver maneuver to prevent postoperative tubing protrusion. Each lever was placed with gentle traction, which helps demarcating scrotal septum. After adding local anesthesia, sharp dissection was carried out. This maneuver helps identify scrotal septum, thus makes dissection much quicker and safer. As shown, scrotal septum is fully dissected, and it also gives better view of the proximal corpora. Right corporal stage suture was done with Vicor 20 UR6, where corpora is bent. If it's too proximal, distal dilation will be quite difficult due to the angulation. If too distal, tubing may cause patient discomfort after the surgery. After adding 2 ml of local anesthesia to proximal corpora, incision about 1.5 cm was done with 15 blade. Proximal corpora was dilated and measured with furlough inserter. Distal corpora was also dilated and measured with follow inserter. When dilating distal corpora, penile axis should be aligned to prevent crossover. Same was done to left side, and cylinders and reservoir were prepared according to the measurement. Reservoir was placed at right radius space. If patient feels pain at this point, local anesthesia can be added under the direct vision, as prosthesis could be prepared only after the measurement, and it takes less time to prepare the reservoir. Placing it ahead of cylinders could save time. Reservoir was filled with cell line accordingly. Left cylinder was placed with follow inserter. With gentle traction by Bailey Charlson, it's quite similar to scrotal approach. Stay suture was tied and cut. Same was done to the right side. Tubing was trimmed down and connection was made. Pump was placed to mid-scrotum. Passing was done before the closure. Tartos fascia was marked with mosquito clad for meticulous repair. Jackson Pratt drain was placed. Continuous suture with 5.30 was done to repair the tartos layer. Skin was repaired continuously with nylon 50 separately from the tartos fascia. Compression dressing was applied for a day.
So actually, in April of 2015, our Federal Drug Administration, known as the FDA, approved placement of the coloplast reservoir in an ectopic or high submuscular location. So in our country, it's perfectly legit and no longer considered off-label. So we're going to stop right here, and this will give you an opportunity to address any questions that you might have had from the previous 7 videos. And while you're thinking of your questions, I'm going to give the faculty an opportunity to comment on anything they'd like to say. I think, David Ralph, didn't you have a comment you wish to say?
I was just really wanting to ask Sean how much is safe. You're using a lot of lidocaine. How much is safe and what volumes? Because a lot of these patients are cardiac patients. I mean, I get asked to put in them under local anaesthetic when the anaesthetist says this guy's not fit, and you have to know what quantity of local anaesthetic you're going to use.
So,
because you're using a lot.
Yeah, I'm using a lot. Right. So I'm using less than 35 cc's per cases. In general, that's the reason why I'm using a 1% lidocaine and 0.5% of bupivacaine. Nowadays, I'm trying to use rather than bupivacaine to the ropivacaine, which is lower cardiac toxicity. So those can be of good help. These days, I also add phenol citrate, an Amplovit, which traditionally we believe that only works well with the CNS blocks, but it turns out that it has a pretty good effect on the peripheral nervous system as well. So my patient usually don't need the narcotics for post-operative, pain.
They go home the same day?
They go home at the same day and come back tomorrow morning for the dressing.
Any other questions or comments from our board? Any comments or questions from the audience? Oh, wonderful. So
Steve, I got one.
Yes.
Do you think, I like the way that your video with the ectopic and then I think it was Darren's as well with the laparoscope looking up. Do you think that should be common practice with the ectopic placement? because I've got a feeling that in the years to come, we're going to see a lot of intra-abdominal reservoirs, and I already have seen a lot of very subcutaneous reservoirs, because presumably when you look down, you should see the muscle belly anterior to you.
One thing that I have not put in that video and needs to be stressed is that when you're palpating the pubic tubercle, you have to keep pushing on it until you get it squeaky clean. So there's no fascia, no scarpus fascia, no nothing. You feel the actual nodule of the pubic tubercle. And if you do that, that means that you're going to get it posterior to all the muscles of the abdomen and anterior to the transversalis. And I think you're right, David. Early on when I started doing it, I had a lot of subcutaneous ones too because I wasn't getting deep enough. And the way to get deep enough is to clean the pubic tubercle completely clean, and then when you put your clamp in, you just go in like that and up toward the head. We initially used to describe it as passing the clamp toward the ipsilateral shoulder, but that also gave us a lot of sub-Q reservoirs that were palpable. And so now we say pass the clamp toward the head.
But have you abandoned your original approach? What about the very thin patient? You talk about really thin patient.
Yeah,
you know he's going to feel the reservoir.
The thin patient, you got to tell him he's going to feel it. And you probably would want, if it were me, I would go back to the traditional intraperitoneal on a thin patient. But, people feel interstems and pacemakers and stuff like that. So if you warn them that they're going to feel it, it doesn't bother them. Okay, first question.
I'm Dr. Rana from India. Actually, I want to ask about the putting IPP in the patient who has small phallus post epispadias and extrophy repair.
Are you talking about in patients that have had a phalloplasty for that condition?
Not phalloplasty, they have small phallus with ED and the prosthesis in these patients.
Well, these are just going to be patients, normal IPPs, but you're going to have to use a smaller model. The trouble with these groups of patients, the epispadiac patients, is that they're going to have a cord E. So you really do have to make an assessment because you're not going to be able to straighten that penis by either incision, modeling, anything on the shorter side, because you're limited by the neurovascular bundle. So you have to, they have to have a good sized penis if you're going to do that. But there's no difference. Clearly in these patients, a lot of them are going to have had multiple operations, atrophinovs, etc. And you probably want to do an open reservoir placement in that patient.
If you are just mentioning about the small penis, I would like to say about something. We usually regard Asians have a very small penis, but I want to stress out that the usual size of my cylinder is 18 or 20 centimeters, which is pretty similar to the US size. So before the surgery, I think that for the Asian patients who looks like have a small penis, preoperative corporal relaxation with either with artificial erection with the saline or trimix is very important. So we don't undersize the actual size of the cylinder. That's what I'm thinking.
Thank you. Yes, sir.
As regards ectopic placement of the reservoir, what are the incidence of complications like infection, like hematoma, like erosion into the peritoneum? And what are the solutions if you develop infection? It's easy to remove the reservoir or not?
Dr. Perito?
This is going back and actually addressing what Dr. Ralph asked as well as you're asking. If you look at patients with low BMIs and smokers, and this is an abstract that will be presented at the SMS, you'll find that you're going to have a higher incidence of migration into the peritoneum. When I say higher incidence, it's 2 out of several thousand, although we don't know if there's others out there. The transversalis is very, very thin in these patients with low BMIs and smokers. So, as you were referring to before, David, I'm sure we're going to see a higher incidence of reservoirs that might have migrated into the peritoneum. As far as higher infection rates, no, there doesn't appear to be any of those. As far as bowel bladder vascular injuries, the reason we're placing them high submuscular, whatever language you want to use, and I like Alan's language because it emphasizes to keep it medial and high. You're not going to have any increase in bowel bladder vascular. The only reason that I don't, ectopic on every, or high submuscular, whatever you want to call it, is because it hurts. It's very painful for the patient for about 2 to 3 weeks. But otherwise, you know, there truly is no other reason other than now this possible new delayed presentation of migration into the peritoneum, and that abstract will be at the SMS this year.
Could the AV people put up the second 1B? Okay, Mohammed, you can give us Dr. Hasbos from Saudi Arabia.
Okay, thank you. My question to the infrapubic approach: how easy can we access the distal corpora if we find severe fibrosis, Peyronie's disease, and some plaques? Because the usual classic approach for scrotal or penoscrotal, we can extend and go, and immediately under vision we can remove the plaques or something like this. So my question to the two experts who presented the infrapubic approach: how easy can this be done?
As you're going to see in a little bit, that in Miami we approach these plaques through something called the scratch. And when doing this internal disruption of plaques via the scratch, we use a nasal speculum to gain access to the penis. We actually have in our hospital 140 millimeter nasal speculums to gain access to the end of the penis. So
this can be done blindly?
Blindly, as you'll see coming up in one of the videos coming up in a little bit. That would be the internal disruption of a plaque. Now, do you guys do a degloving or anything?
Yes, so I mean there are certain steps you can use, as he was mentioning, the scratch technique. Rosello dilators can also disrupt the plaque internally. Dr. Wilson has got a double-sided scissor that can also be used for that. But for patients for which there is still problems distally, you can close the wound once it's in, and then you can actually do a counter incision, a deglove incision. Occasionally can be done.